Well, hello, audience. I'm David Chu from Malaysia. Some of you may know me. But today we have a wonderful audience, and we also have some great speakers for you. I'd like to thank Palacademy for organizing this. Talking about various different items in hip arthroplasty. In particular, we try to think about how we can make things better for ourselves. I'd like to draw your attention to the fact that on your side there's a little panel that allows you to ask questions. It's a Slido panel. And as you know, with Slido, we rank the questions and you have an idea as to whether you can actually, your questions being accepted because people will vote for it. You can vote for your questions. Please do so. We'd love to hear from you. We have a wonderful panel for you today from Sweden, from Thailand, from Singapore, and myself from Malaysia. So without further ado, let's continue. This first speaker will be Dr. Paul Panichkul. He's from Bangkok. So we'd like to hear from him and have his thoughts about the subject. Paul?
Hi, everyone. My name is Pontakorn Panichkul from Bangkok Hospital, Thailand. You can call me Paul, which is easier for you. Today, I would like to give a short talk about the complications in the hip arthroplasty. So this is my disclosures. So there are several complications in the hip arthroplasty, but we would like to focus on the periprosthetic fracture today due to the time limitation. As we all know that there is an increased rate of the periprosthetic fractures with the complicated patients, which we cannot control, such as the hip fracture patient, elderly people, osteoporotic patient. However, the things that we can control to reduce the risk of the periprosthetic fractures are the fixation and the surgical approach. From the American joint registry show that there is a trend to use the cemented stem in the elderly people. And in Thailand also, cemented stem is the most commonly used in the total hip arthroplasty, but cemented stem is the most commonly used for the bipolar hemiarthroplasty. So I think this is the common in every country. But when we look at the data from the UK Nature Registry, we found that the most common intraoperative complications is the calcar crack, which happen mostly with the cemented stem. In Australian Joint Registry 2021, the cemented stem showed the more early revision rate than the cemented stem in terms of the increasing of the early femoral fractures and loosening rate. The American Joint Registry also confirmed the same finding that the cemented stem has a better survivorship due to the periprosthetic fracture when compared with the cemented stem. Nowadays, we all know that there is an increased interest of the direct anterior approach. In 2020, 45% of the surgeons in the United States use the direct anterior approach as the primary approach. In Europe also, this is the data from the Netherlands, show that there is an increasing of the direct anterior approach usage from 4% to 37%. Direct anterior approach may be the ideal approach due to the faster recovery and there's no hip precaution with the lower risk of the dislocation. However, the direct anterior approach has a high chance of the periprosthetic fracture. And this is the biggest series regarding to the complications of the direct anterior approach, including 5,000 patients done by direct anterior approach expert in the United States. And they found that the most commonly complications in direct anterior approach is the periprosthetic fracture, such as the calcar fracture, catertocanthal fractures, and femoral shaft fracture. And these are the example of the periprosthetic fracture in direct anterior. You can see this is the calcar crack and canal perforation. Several papers show that the direct anterior has a risk of the periprosthetic fracture with some type of the cemented stem. We are also report and published in Orthopedic 2016 and show that the collarless type stem with the taper wedge morphology has a high chance of the subsidence and periprosthetic fracture and also increase the rate of the loosening in the direct anterior approach. And how to prevent this kind of complications? The first option, we may consider using the cemented stem with the collar because the collar will distribute the force throughout the calcar area to prevent the periprosthetic fractures and also the stem subsidence. And these are the examples of the case with the calcar crack treated by wiring and consider using the collar stem to prevent the further crack down to the proximal femur. And this, the cadaveric study from JBJS 2020 also confirmed that the collar is the protective things against the periprosthetic fracture. The data from UK Joint Registry show that the calcar collar increased the resistance to the periprosthetic fractures, which published in 2019. We also confirmed and performed the meta-analysis study compare between the collarless and collar type stem in direct anterior approach, and we found the same finding that the collar stem lower the risk of the loosening and also the fracture. The second option is we may consider using the cemented stem, especially in the elderly people. And this study from journal Arthroplasty this year confirmed that the cemented stem reduced the risk of the periprosthetic fracture for 87% at 90 days and 81% at 1 year. Another study from journal Arthroplasty this year showed that the cemented stem lowered the risk of the revision for the periprosthetic fracture in the elderly female. And finally, the cemented stem can be done safely in direct anterior and can reduce the number of the fractures, revisions compared to the uncemented stem. So in conclusions, how to avoid these type of the complications. The first thing we need to know to assess the risk of the patients, we have to know the potential difficulty of the cases. And for sure, we need to have the proper surgical technique and exposure. Finally, the proper implant selection is the key. We may consider using the collar type cemented stem or the cemented stem to reduce and prevent the periprosthetic fracture. Thank you so much for your attention.
Thank you so much, Paul. It was a good talk. We all enjoyed it very much and look forward to discussing it with you soon. The next speaker is Georgiou Chatzeguru, who actually comes from Sweden, from the University of Gothenburg, and he'll be talking to us about patients who are at risk of periprosthetic fractures. Georgiou?
Hey from Sweden. I apologize that I was not able to participate live in this symposium due to a full booked schedule. And I hope my presentation will generate some discussion about periprosthetic fractures. My thesis was about periprosthetic femoral fractures after total hip replacement, which you can download free at the link you can see on the right top of this slide. This is me, and these were my supervisors. Although hip arthroplasty is in general a very successful clinical intervention, there are still some areas where further improvement may be done, and periprosthetic femoral fracture is one of them. In this figure from the Swedish Hip Arthroplasty Register, it is illustrated very clearly that patients with periprosthetic fracture have the highest mortality in comparison with all other complications after hip arthroplasty. So the prevention of periprosthetic fractures may not only improve quality of life, but in some cases lengthen someone's life. Therefore, it is very important to study which patients have a higher risk for periprosthetic fracture. And the study of this complication is not so easy because, fortunately for the patients, it is relatively rare, as you can see in this diagram from an epidemiological study that included all first-time reoperations due to periprosthetic fracture close to a primary stem. Therefore, it is not unusual that some studies about periprosthetic fractures compare apples and oranges, while some other have a very mixed material. And even if someone manages to compare apples and apples, there will always exist some subcategories that may bias the results. For this reason, I have chosen to present the most studied and less controversial risk factors of periprosthetic fractures. Patients with hip fracture, femoral head necrosis, or inflammatory arthritis have a higher risk for periprosthetic fracture compared with those who suffer from osteoarthritis. Increasing age is also a well-documented risk factor. But when it concerns gender, the literature has not been unanimous. In some studies, it is presented not as a risk factor, while other studies document only women or other studies only men as patients with higher risk of periprosthetic fracture. In two publications, men or women had a higher risk for fracture depending on the type of stem fixation or the type of fracture. The one study investigated revisions during the first 2 years after the primary hip arthroplasty and found that men had a higher risk in the cemented group, but a lower risk in the uncemented group. The other study, which analyzed the two most common cemented stems in Sweden, showed that men had a higher risk for fractures around the stem, while it was more common for women to suffer fractures distal to the stem. A probable reason for this difference is explained in the first study, where authors noted an interaction between age, gender, and type of fixation. Uncemented fixation had a higher impact in women than in men. Men at the age of 50 to 59 with uncemented stem had 3 times higher risk for periprosthetic fracture compared to men with cemented stem, while women at the same age and with uncemented stem had 7 times higher risk than women with cemented stem. At the next age group, between 60 and 69 years, the relative risk increased in men from 3 to 4 times, but in women from 7 to 13 times. And now I come to a risk factor that a lot of research has been done, and there are potentials for improvement. Many studies have shown that the risk of periprosthetic fracture is higher in uncemented stems, and especially for intraoperative and early postoperative fractures. A study from the Australian Joint Replacement Registry concluded that they may have to train the new generation of orthopedic surgeons in cementing techniques so that fixation in patients older than 75 years will be a reality. Another study from the Norwegian Arthroplasty Register stated that uncemented fixation should not be used in THAs in women over 55 years of age. And a study from the Netherlands, published this year, suggests that female patients older than 75 years would benefit from treatment with a cemented stem. The positive is that some units have already begun to change their policy in line with these recommendations. At the annual report from the Norwegian Arthroplasty Registry, we read before 2 years that they aimed to use cemented stems in 95% of all patients over the age of 70 years. Last year, a study from Denmark showed how they managed to reduce the number of early periprosthetic fractures by using cemented stems instead of uncemented in women older than 60 years. In Sweden, it seems that we are very close to what our neighbors in Norway are aiming to do. And regarding hemiarthroplasties, it is used almost only cemented fixation. Other factors named in the literature are shown in this slide. Thank you for your attention.
And really concerns what you do with patients with very, very bad osteoporotic bone. This tends to happen in patients with hip fractures. Just I'd like to go back to what Paul was saying. That slide really has to do with presence or absence of a collar. This is in cementless implants, and this is the first thing. There was a paper from Medding and Ritter, and it basically said in long term it makes no difference whether you use the collar or not. I'm sorry, Paul, but that's what it says, and it's a very large registry type paper. The next one is this paper from McGill from Belfast. Basically, over this time, so many things have happened to all kinds of joints that we don't know how that makes a difference. And this is a commissioned research from the Corral people that shows the Corral with the collar does better. But next slide, please. Actually, if you look in the British registry, long term, almost all cementless implants do worse than cemented ones. So I agree with you that next slide. That we're better off cementing the implants rather than trying to fracture them, trying to fit the implant to the patient, to the patient to the implant. So I like the comments of Nils and Sokchen and Paul about this.
Yeah. I agree that I think the cemented stem can use in every type of the bone and in every patient because it fit everything the stem in the bone of the patients. But I think but in some country or some center they train to use the cementless stem. So if we focus on the periprosthetic factors, we all know that the cementless stem increase the risk of the fracture, especially in the elderly people. But in some type of the center or some surgeon, if they want to use the cementless type stem to shorten the time or to avoid the some kind of complications of the emboli or something, they may consider the collar. And the literature also show that in the update one show that the collar may be the helper to prevent the further periprosthetic fractures or after the surgery. And also agree with Professor Chun regarding the undersizing of the stem. That you show that the collar may be, if they use it the wrong way, they will be end up with the undersizing of the stem. Agree, but
it will cause a fracture as well. We whack it in too hard.
Yeah.
What do you say? You come from Sweden. You use a lot of cement there, a lot.
Yeah. I use a lot of cementless. Yeah.
Nils.
Well, we do we do use uncemented stems a lot also, but mostly in younger patients. So the kind of patients we're talking about today, the elderly patients, receive mostly cemented stems. And as has been said before, it is mostly due to the reduced risk of periprosthetic fracture when you do a cemented stem. And then also in the long term, a cementless stem, an uncemented stem, will work best in healthy living bone in a young person. It is dependent on osseointegration. If you put an uncemented stem in an old patient with weak osteoblasts, if you allow me to put it like that, it won't grow in and you will have a risk of loosening in the long term. Even if you don't get a periprosthetic fracture immediately, you won't have a good and stable fixation. So in our opinion, in Scandinavia or most parts of Scandinavia, for the elderly patient and definitely for the fracture patient, the cemented stem is the safest solution.
Agree.
So we're all in agreement then. Unless the Singaporean disagrees. I know you use a lot of cementless implants there. So Fen, you have 20 seconds to disagree.
No, actually, I mean, in my practice, I see a lot of elderly ladies with hip fractures. So I would say cemented stems is actually my mainstay for dealing with elderly ladies with hip fractures. Because I can walk them the next day without worrying about having a undetected calcar crack.
Mm-hmm.
So yeah, so the mainstay for me is still cemented for the elderly ladies with fractures.
So Sokchen Stock is next. She's going to talk about the Singaporean experience with these hip fractures.
Hi everyone, I'm Dr. Tan Sok Chen, consultant orthopedic surgeon from Hip and Knee Orthopedics. I'm currently practicing at Mount Elizabeth Novena Hospital, Singapore, and it's my pleasure to be invited by Harius to be giving a talk on typical hip fracture patients as part of the webinar titled How Can We Improve Hip Arthroplasty Outcome in Arthritis and Hip Fracture Patients? A brief introduction about myself. I'm a double fellowship trained hip and knee surgeon. I spent 1 year training at London Health Sciences Centre, Ontario, Canada, where I first met Dr. Paul Panishku, one of the speakers in this panel. I also spent a year at Nuffield Orthopedic Centre in UK. Hip fractures patients present a significant challenge to our practice. Up to a third of these patients die within a year. And in Singapore, it presents a significant burden on healthcare costing. Within a span of about 15 years, hip fracture admission has increased from 2004 to 2007. So it's sort of about double in the number of hip fracture admissions. And this could be due to our aging population. And part of the cost is also attributed to the care after the fracture fixation. A lot of our patients, they don't go home, they go to community hospital or nursing homes when after discharge. So there's an increase in all-cause mortality risk up to 5 years after hip fractures. Men tend to die from stroke, cancer, and pneumonia, whereas the women tend to die from coronary artery disease and urinary tract infections. In this local study comprising of 36,000 patients, mortality was found to be increased in male patients, older patients more than 85 years old, those with a severe Charlton comorbidity index, those with trochanteric fractures as compared to cervical fractures. The earlier cohorts tend to do worse as compared to the more recent cohort of patients. Surgical site infection worsens the mortality rate. In this study, it was showed that early deep surgical site infection tripled the 90-day mortality rate and more than doubled the 1-year mortality rate in patients with hip fractures. In a cost analysis of bundled payment for hip arthroplasty for hip fractures compared with degenerative joint disease, it was found that the femoral neck fractures incurred a greater amount of healthcare costing as to what was projected, whereas the cohort comprising of degenerative joint disease, they actually cost less. It costs less to treat them as to what was projected for that disease score. So the cost of care essentially is significantly higher for hip fracture treatment as compared to osteoarthritis of the hips. So in this another propensity matched cohort study looking at 42,000 patients, and this is a study comparing total hip replacement in hip fractures compared to total hip replacement in osteoarthritis of the hips. It was found that hip fractures had a longer operative times compared with arthritis hips, had a longer length of stay, had an increased incidence of complications, higher odds of unplanned readmission, higher odds of being discharged to an inpatient facility as compared to arthritis of the hips. And importantly, these differences exist despite matching of other preoperative risk factors. Another important finding was that the risk of complications of surgery for hip fractures was twice to that of arthritis of the hips. Similarly, in this multivariate and propensity match analysis, looking at 139,000 patients, when we compared the femoral neck fractures with OA hips, mortality within 30 days was higher in patients with hip fractures, was higher in patients in hip fractures in terms of the morbidity, higher risk of reoperations, higher risk of readmissions. Thus, we can see that hip arthroplasty for hip fractures as compared to osteoarthritis of the hips are very different kettle of fish with very different in outcomes and mortality rates. And this difference is attributed to the disease condition itself rather than just from the pre-existing comorbidities. Though we cannot change the disease condition, but we can improve the outcome because we can decide on the surgical technique. And my next speaker will explain more on what can be done to improve the outcome. Thank you. And if there's any questions or anything you want to find out about the papers, do feel free to email me at this address.
Thank you so much. As you say, it's a real big challenge in Singapore. I remember visiting some friends in Tan Tock Seng Hospital recently, and there was just trolley loads of elderly, frail women, waiting to be admitted, and they were telling me that these people coming in and out. I'm sure it's a phenomenon that's repeated throughout of Europe. The next talk will be by Professor Mike Reid, who hails from York. Mike Reid is in charge of the UK Joint Registry, and he is going to talk to us about why bone cement matters. Mike Reid.
Hi, my name's Mike Reid and I'm an orthopaedic surgeon. I work in the north of England, and my role today is to talk about bone cement and really the outcomes for different fixation methods, some health economics, but also the use of high-dose dual antibiotic-loaded bone cement for infection prevention. So this is data from the UK National Joint Registry. And what you can see here is that over the years, really over the last 20 years or so, is that the use of uncemented implants has really begun to drop off, and also the use of cemented implants. And there's been a big increase in the use of hybrid hip replacements, and that is with a cemented stem and a cementless cup. And as of last year, they are now the most popular type of fixation in our registry. So we're now out to about 17 years in the National Joint Registry, and what this data shows is that actually the results of these types of fixation broadly are pretty similar. If you're being scientific, then uncemented fixation does have a higher failure rate than cemented and hybrid, but otherwise they're largely similar, and there's only really 1 or 2 percentage points at 15 years. So the differences are fairly minimal. If you take the ceramic on poly bearing as an alternative, you'll see that the differences are, again, pretty minimal between the types of fixation. So probably this argument is not best placed on revision, although both the cemented and hybrid versions do appear to be better in terms of revision. It is pretty marginal. So what I wanted to focus on here is this very large analysis, which was done using both the UK and the Swedish registry data. It was published just a couple of years ago. And this is an important paper because it looks at really the cost effectiveness of the choices that we make around implants. So I've taken just the males because of the length of this presentation, but I can tell you that it's exactly the same in females. Very, very similar trends. And what you've got here is that for male patients, you've got groups of ages. So you've got the less than 55s, then the slightly older patients going up to the age of 85 plus in the bottom rows of the chart. And if you look at the far right, you'll see the probability that they're most cost effective. And if you look at the patients that are less than 55, the highest probability is ceramic on polythene cemented hips. Now, actually, there is still some uncertainty in that age group, which is why the probability is not actually very high, but it is at least highest probability in the cemented ceramic on poly group. And in the age of 55 to 64, it's exactly the same. It's becoming, if you like, more robust with almost 50% probability that it's most cost effective. When you get 65 and older, then actually the bearing choice changes, and metal on poly appears to be the most cost effective. And if you go right down, it's a slightly obscured slide, but if you go down to patients over 85, then a metal on poly cemented hip replacement is by far the most likely to be the most cost effective option. So if you are going to use cement, then what should you use? So there's some debate internationally whether you should be using plain cement or indeed antibiotic loaded cement. And we've had two very large papers come out of the UK recently. I was involved in one of them, but I think this puts to bed that argument, because essentially this compares the failure rate both in terms of infected revisions but also all cause revision in these patients. So the first paper here is around hip replacement, and what they showed was a significant reduction in revision for infection, but also aseptic revision in some 400,000 patients. And then the paper that I was involved in, we had 700,000 patients, some of which had plain cement and some had antibiotic in the cement. And there was a much lower risk of revision in those that had antibiotic cement. So the risk of revision was about 0.75 compared to 1, if you like, in the plain cement. So now I want to move on to hemiarthroplasty for trauma, and this is a really important question. So should we be using cement or not for these patients? Now, this has been debated long and hard in recent years, particularly with contemporary implants, but there has just been this fantastic trial has just reported in the last couple of weeks. It's in the New England Journal of Medicine, and I think it very definitively answers the question. So this was a randomized trial in many centres across the UK, and they compared cemented hemiarthroplasty with uncemented, and they used contemporary implants for the uncemented. And what that shows is that there is a difference in EQ5D, so health status was better in the cemented group. It's a fairly small difference, but significant. And the incidence of periprosthetic fracture was dramatically better in the cemented group, some 4 times reduction in terms of the odds ratio. So, and of course, what we know is that the cemented implants do last a long time. So we've got better short-term results, but we also have excellent long-term results. This is our results, which have not actually yet been published, but just about to go off for publication. And we've got over 90% survival at 10 years for the hemiarthroplasty implants, and of course, far lower survival for the patients, some 7% at 10 years. So we know that we get good early results with cement, and we get good long-term results too. So if we are going to cement the hemiarthroplasties, then which cement should we use? So this is work which has been done some years ago, and this is electron scanning microscopy, which shows a biofilm actually growing on cement. And this is a standard cement, antibiotic cement, low dose single antibiotic. And everything you can see here, you can see the green, which is live Staphylococcus, and you can see the red, which is dying Staphylococcus. But the message here is that biofilm will grow on standard antibiotic cement. If you take high dose dual antibiotic cement, and this is clindamycin and gentamicin, it's copal cement, and you'll see just the blue staining in the background, which is essentially extracellular polysaccharide, and there's no bacteria growing on there. So you don't get bacteria growing on cement which has high dose dual antibiotic, at least in the relatively short term. So we decided to do a pilot study. This is a randomized trial of 2 different types of cement, and this was a large study. It was done in my organization, some 848 patients involved in this, and they were randomized to to have these two different types of antibiotic cement. One, the Copal cement, was higher dose and had two different antibiotics. And the results of this were quite striking. So what you'll see is the deep infection rate was reduced in this trial in the Copal group, and the superficial infection rate also dramatically reduced. So actually quite a potent effect. So there are some flaws in this trial, mainly, in fact, it was done in one centre. We are going to repeat that, and I'll show you that in a second. Now, one common question is that, well, if you use this high-dose dual antibiotic cement, do you actually breed resistant bugs? And so we've looked at this in some 1,900 hemiarthroplasties. 680 of them had standard antibiotic cement, and 1,200 had the high-dose dual antibiotic cement. And you'll see that the risk of developing an infection was lower, of course, as we know from the trial results. But there is the risk of having a resistant infection to clindamycin was lower, significantly the same, I should say, but certainly not higher. And again, comforting results in terms of resistance to gentamicin and resistance to both, which is slightly obscured there. But again, very reassuring that we're not breeding resistant bugs by using high-dose dual antibiotic cement. So the take-home message from this data is that the high-dose dual antibiotic cement in hip hemiarthroplasty does reduce deep infection rates, and it's not driving antibiotic resistance. So we've just finished a very large trial of several thousand patients across multiple centres in the UK to answer this question definitively. And we hopefully will know the results by the end of the year and be publishing that. So watch this space in that regard, but hopefully that will confirm what we found in the pilot study. So I'd just like to thank you for your time, and I look forward to any contact from you.
Well, that was a good talk from Mike. So it would seem that the UK registry and the Swedish registry are in agreement. It doesn't matter what kind of articulation you want to use. If you want it to be cost effective, you should be using a cemented stem. So, Soktuen, you talked about this problem in Singapore, where everyone's getting older. So actually, I looked it up in the CIA. The CIA told me that, in fact, you're pretty old, but you're not the oldest. Actually, Japanese and Thais are older than you. So I think Paul has a bigger problem than you. But Malaysia is, as yet, not so bad. Actually, we have a broader bottom to support our pensions. I'm sorry, Soktuen, you have to work harder for the rest of your life because they don't want to do the pension for you. So our problem is that actually there's bone stock loss in our patients, and they are not very mobile. How do we improve that prior to surgery, or even after surgery?
I think we are working on what we notice in our patients is that we have a large proportion of patients who are vitamin D deficient. I think it might have to do with our climate. It's too warm and sunny, so everyone hides indoors. So we are rapidly raising awareness of vitamin D deficiency, and increasingly a lot of patients coming, and they are quite open to having their vitamin D levels checked. And very often I find them in a very deficient or insufficient level, and we are quite aggressive in topping these levels up. So we are hoping that all these measures will help to reduce going forward risk of osteoporotic fractures. We're also raising a lot of awareness about this condition. So even orthopedic surgeons, we are all roped in to treat osteoporosis aggressively after some form of fractures. So these are the things that we're doing.
Okay, just going to show you the next slide now. And can we have the next slide, please? So this is one from the UK registry. Basically, it says, basically, as Mike says, that there is no no difference between what kind of implants you use as far as the registry is concerned, where it comes to survivorship. But if you look at pain, it would seem that some implants cause more pain than others. We're running out of time, so what we're going to do now is go to Niels Heiler, who's Professor of Orthopedic Surgery at Uppsala University, to give us an idea of how we should be doing our cemented hips. Niels?
Ladies and gentlemen, dear Chairman, thank you very much for the invitation to this webinar. It's a pleasure for me to be with you, even if I regret not being there with you in person. But the pandemic is hopefully going towards its end, and so perhaps in the near future we will be able to meet physically again. My task is to talk to you about cemented fixation of implants in hip fracture patients. And thanks again for the invitation. I'm looking forward to the discussion that we may have after my presentation. So some of you might think it's absolutely crazy to even think about cementing in elderly comorbid patients. And that's exactly the kind of patient that we're talking about when we're talking about hip fractures. Those patients are very often sick, elderly, frail, and some of you might think, isn't it a total madness to pour cement into the femoral canal of such a patient? So my task in the next couple of minutes will be to try to convince you that this is actually a very good idea. There is a lot of evidence indicating that uncemented hemiarthroplasty is a bad procedure in the hip fracture patient. There are numerous registry and other observational studies showing this, and this is one of the latest and largest studies. It's from a Norwegian registry, and you can see the comparison of cemented hemiarthroplasties in red with uncemented hemiarthroplasties and the implant survival on the y-axis. And you can see that the risk of revision for uncemented hemiarthroplasties is much higher, their prosthesis survival is lower, and the risk of revision of uncemented hemiarthroplasties is about 1.5-fold when compared to the cemented hemiarthroplasties. The reasons for this are a severely increased risk of periprosthetic fracture and a slightly enhanced risk of periprosthetic infection when you're using cementless implants. So some of you might say this is just observational research, registry research, the level of evidence is low, and I agree, there is a higher level of evidence, that's the randomized control trial, and there are numerous randomized control trials investigating uncemented and cemented fixation in hip fracture patients. So this is one of those studies. It's a study comparing uncemented with cemented hemiarthroplasty in 200 patients, and you can see there are more complications when you're using uncemented hemis. And the same is true if you're looking at total hip arthroplasties, another randomized control trial showing a higher rate of complications when you use uncemented total hip arthroplasties in hip fracture patients. These are not the only two randomized trials. There are many more. There are so many trials that formal meta-analysis has been performed. And this meta-analysis was published 2 years ago by Kong and co-workers. And when you pooled all the data from the various randomized trials together, there was no question that cemented fixation is favored over uncemented fixation when doing total or hemiarthroplasty in hip fracture patients. So let's now look at a typical clinical case and go through the technique that we use when we do cemented arthroplasty. This lady came in with displaced femoral neck fracture type 4, according to the Garden classification. She's 65 years old, she is very active, she doesn't use any walking aids, and she's fairly healthy, no significant comorbidities. According to our local routines, she would get a cemented total hip arthroplasty, as you can see here. And we would, in a fracture patient, also consider using a dual mobility cup. The evidence supporting the use of dual mobility cups is slightly weaker, and that's a point that we might want to discuss later on today. So let's now stepwise walk through the process of a cemented total hip and look at the modern cementing technique that is recommended today. So the first step is that in modern cementing techniques, you use a distal plug, whether it's autologous bone or plastic, doesn't matter, as long as you put in a plug that enables you to put up a certain amount of pressure in the femoral canal. So the next step is high pressure irrigation. You want to clean the femoral canal from all sorts of debris, from blood, from fat, and this also reduces the risk of any emboli occurring during this process. So this is a very important step, the high pressure irrigation. After this, you perform distal filling of the femoral canal which means you put your cementing device all the way down to the plastic plug or bone plug that you inserted previously, and you then fill the femoral canal in a retrograde fashion. The last step before putting the stem in is proximal sealing and pressurization, because you want to extrude the cement into the trabecular bone to get an optimal interlock of the cement with the surrounding bone. So this pressurization moment is important, but I have to say, we'll come back to pressurization in a moment when looking at a different sort of patient. Remember, the patient we're looking at now is a healthy 65-year-old. So what about the sick and elderly patient? A typical case would be this gentleman. He's 85 years old. He has atrial fibrillation, hypertension. He uses walking aids and doesn't actually walk a lot. He also has a displaced femoral neck fracture type 4, according to the Guardian classification. And according to our local routines, this patient would be operated with a cemented hemiarthroplasty. So no question about using cement in this case, but definitely a hemi rather than a total hip arthroplasty. How dangerous is cement in this category of patients? Well, actually, there are some quite alarming estimations of how common bone cement implantation syndrome is. Figures up to 28% have been reported, but then it is important to note that in these cases, this doesn't mean death on the table. This rather means loss of saturation and a loss of systolic blood pressure. And you all have seen these slightly alarming pictures taken by cardiography, by ultrasound investigation during cementation. You can see those emboli passing the right ventricle or the right atrium going right into the lung perfusion system. And so this is, of course, a dangerous moment, and I'll tell you how to minimize the risks associated with it. The trick is to adapt your cementing technique in the sick and elderly patients, which means that you really use excessive femoral irrigation to really clean the femoral canal from all the fat that there is, because it's the fat that causes the emboli. It's not the cement itself, usually. So the first step is to use really excessive amounts of high pressure irrigation to get a really clean femoral canal prior to cementation. And then you have to adapt your cementing technique in contrast to what I told you for the younger and active and more healthy patient. You would, in a sick and elderly patient, not use proximal sealing and would not use excessive pressurization, because that's when you get your emboli. Talking about correct cementation technique also means that you have to think about the depth where you put your distal plug. And this is a post-operative image that I would not like to see in the morning after the night shift has done the hip surgeries. You can see here that the plug has been put much too distally, and you get a cement mantle or a cement tail that's several centimeters long. It doesn't matter as long as you don't have to reoperate this patient, but should this patient suffer from a periprosthetic fracture or a joint infection and you would have to revise this patient, it would be a tedious amount of work to get this cement out. So when putting your plug, please put it at the desired depth, which is just a few millimeters below the tip of the prosthesis. That will prevent you from getting these long cement tails into the femoral canal. Okay. So I think we've got the most important technical tips addressed. And then you might ask, well, is this just personal opinion or is there good evidence behind it? And I would say there are several quite heavy national guidelines supporting what I just said. One of the heaviest advices comes from the National Health Service in the UK, which in its NICE advice guidelines says that in femoral neck fracture patients, use cemented implants because that results in less pain, better function, reduced risk of periprosthetic fracture, and no difference in mortality when compared with uncemented implants. So to summarize things, I would like to give my take-home message. In the patient with a displaced femoral neck fracture who's below 80, who's active, who's healthy, use a cemented total hip arthroplasty. Whereas in the older and more comorbid patient, and in patients even if they're below 80, who have a very low degree of activity, use a cemented hemiarthroplasty, but please remember to adapt your cementation technique, do it without excessive pressurization, and think about cleaning the femoral canal thoroughly. Finally, do not try internal fixation in displaced femoral neck fractures. It always fails. So even if you consider the patient to be very sick, don't try internal fixation, because you will just have to give him or her a second operation at a later stage. And having said that, I would like to thank you very much for your attention. These are some pictures from our hospital in Uppsala and an aerial view of Uppsala's old city center. I hope to see you in person sometime. You're welcome to Uppsala, and I might make it to Asia one day. Thank you very much for your attention.
Thank you for a wonderful talk, Niels. I agree with everything you said. There have been some questions about bone cement implantation syndromes, but I think you pretty much answered them. So we have some time for a longer discussion of your topic. Can we go to my first slide? And this is a slide that really covers the risk of infection, whether you do a cemented or uncemented implant. But really, it's down to what question you ask. Certainly in Norway, which is next door to you, when they asked this question, they said, well, does it increase or decrease the risk of infection? They got the answer that was on the right-hand side graph, which basically says that, if you use cement in your antibiotics in your cement, then it's about the same as using an uncemented implant. But in Norway, you can also see that if you use an uncemented implant, long-term survivorship is not so good. So what are your comments about that, Niels?
Well, generally, you have to remember that this is historical work. The data were obtained at a period when there was still a lot of cement around with no added antibiotics. And it is also a time period like the late 90s, beginning of the zeros, where people used only one dose of antibiotics. So both of these things have changed over the years. Today, in most Nordic countries and in the UK, the commonly used cement always contains antibiotics, gentamicin usually. And you heard Mike Reed's talk that you could possibly reduce the risk of joint infections even further by using dual antibiotic-loaded cement. I think there is quite some evidence behind that. And as Mike said, we're waiting for the results of the White 8 trial on thousands of patients. We have a similar trial running in Sweden comparing double antibiotic-loaded cement with single antibiotic-loaded cement to see whether the double antibiotic-loaded cement can even further reduce the risk of infection. The other thing that has changed is antibiotic prophylaxis. Nowadays, we use 3 doses on the day of surgery, whereas historically, sometimes no antibiotic or only a single dose was used. So we have to remember that the data we see here are historical, but the bottom line is still true. Adding antibiotics to the cement reduces the risk for periprosthetic joint infection and the risk of revision. And using 3 doses of antibiotics is, of course, probably the standard of care in most countries nowadays, I believe. So that's my take on this topic.
Thank you. I'd like to move on to the next slide. And the next slide illustrates something very different. Basically, this is also from the Norwegian registry. And you can see here they're comparing 2 cemented implants. And my point is, not all cemented implants are the same. If you use an inferior cement like bone lock, which was quite popular during the time of this paper, you can see that if you use an inferior cement and you use a composite beam stem like the Charlie stem, you actually have a very high failure rate. If you use a polished tapered stem like the Exeter, you do not get the failure rate. And that's only on the stem side. And since our argument is that actually for good bone stability, we really need a cemented femoral stem. And this is something that the audience should know. I like your opinion again, Niels, on this, because you and I are the only 2 big-time cement opponents here. But I want to welcome the Sok-Chuan and Paul contributing here. Please, we have 2 more minutes left to say our piece.
Well, I can only emphasize what you just said. Not every cement is the same. And this paper shows a catastrophic, a very bad cement that was put on the market many years ago. The bone lock cement was a real disaster. But as you can illustrate with this graph, there is a difference between different types of stems. So even if you're using a bad cement, a composite beam stem behaves differently than the tapered stem. But my take on this is, if you use a modern contemporary primary cement like the Palacademy but there are others that are comparable. You can use any stem you want, but the risk of periprosthetic fracture increases when you use tapered stems as opposed to anatomical stems. That is quite certain, and you can see that in many other papers. So irrespective of what cement you use nowadays, consider using anatomical stems, composite beam stems, rather than tapered stems, at least in the hip fracture patients, because your risk of periprosthetic fracture will be increased in the group of patients having tapered stems, even if you use cemented stems. That's an important thing to remember.
Okay. Paul, Sokchen, any comments?
No,
Well, in the 1 minute that we have, sorry.
Yeah, we can go to the audience questions. Yep.
So is there a place for cementless hips? And basically, I think everybody answered this question. Yeah, we think it's less likely. Okay. The next question is, if a patient has a very high risk of intraoperative death, what is your choice of stem type, cemented or uncemented, and why? Well, I just like cement and I use cement in everything. So I guess I'm biased. So let's ask the people who are not so biased. Niels, Paul, Sokchen?
Well, I fully agree. If you do it carefully, if you do it right, as we discussed previously, there is no, there is no reason to go to cementless, even if the patient has increased comorbidities. If you take it easy, if you clean the femoral canal, if you don't use excessive pressurization, it is safe to use a cemented stem, even in the old and comorbid patient.
So I agree. We have to talk to the patient and the family about the risk of the cementation. But if you want to prefer to reduce this kind of the complication, maybe if you want to use a seamless stem, you have to consider with the collar and make it fast, very straightforward broach, and then finish. Make sure that everything went very well and very fast.
Maybe I just want to ask a question to Paul. Because I know you are a strong DAA surgeon. So do you change anything about your technique when you use cementing in DAA?
No. So this DAA we can use in every type of the stem, also the cementless or cemented stem. And I think that there's a trend to use the cemented because the direct entry has a chance of the periprosthetic fractures when compared with the posterior approach. So if you want to decrease this kind of the fracture, the cemented stem may be the option for you guys to reduce this type of the fracture, because as you know that the broaching of the femur is quite difficult in the direct entry for the beginner to adopt this approach. But for the expert, I think, or the well-trained surgeon, I think direct entry can use in every type of the stem, cemented, cementless, or long or short stem.
Well, ladies and gentlemen, we seem to have run out of time. I'd like to thank Paul and Niels and Sokchen for being present today, and in their absence, Mike and Georgius as well. And I'd like to thank Palacademy for inviting us to share our thoughts. Thank you very much and good night.
Bye.
Thank you very much for the invitation. Thank you.
Thank you
for the invitation. Thank you.
Thank you, and bye-bye.